All right, so now we're looking at the non-surgical causes. So things that are not going to make you call a surgeon at 3 o'clock in the morning, and this is kind of, there's a caveat to this because if some of these things go on for long enough, it's going to become a surgical emergency. So you have to kind of gauge based off the patient's vitals, based off their exam and all that. So, and we'll go over that in the future. But the things that we're typically looking for that can cause diffuse or non-specific abdominal pain that's non-surgical is stuff like gastroenteritis. So gastroenteritis is basically food poisoning. You eat something, it contains some type of virus or bacteria, it upsets your stomach, you initially have some vomiting, and then after that you can progress to having diarrhea. The thing to look out for gastroenteritis is if it is bloody or non-bloody, because the bloody one can be caused by certain bacteria that can actually cause a lot of issues. So something like E. coli that can cause something like hemolytic uremic syndrome, especially if you give antibiotics. Those are things to look out for. And then the other really big one is C. diff colitis. So C. diff is a bacteria that lives in your intestine naturally, and so what usually ends up happening is somebody will take an antibiotic for whatever it is, a pneumonia or a cellulitis, and they end up killing the good flora that's keeping the C. diff in check, and now that C. diff has the opportunity to grow and flourish and starts creating this toxin that causes basically the inner lining of the stomach to kind of slough off, and it causes a pseudomembrane. And so it's highly, highly infectious, and it can cause a lot of issues if it's not treated well. So that's one that you would actually have to treat with antibiotics. The next one is constipation, and everybody's aware what constipation is. Basically, you're not pooping, so the stool that's in the colon is just not able to get out for whatever reason. You're dehydrated, you're not exercising, you don't have a high fiber diet, or you don't have enough fiber in your diet, and so this stool will kind of just sit in the colon. And the longer stool sits in the colon, the more water gets absorbed from the stool, making it harder and making it harder to pass as well. And so if you think about it, as you're collecting stool in this area, well, you're gonna basically so let's see, this is your colon right here, and if you start collecting stool in the area, you can start distending the colon, and so this stool is going to start pushing out because there's so much stool that's not coming out, and distension of the colon is going to cause pain and pressure. And so that is why a lot of people end up with abdominal pain with constipation. Now, sometimes if we're depending on where the distension is and where I guess the biggest impaction is, you can have pain not so much in the front of the abdomen. You can have it on the flank. You can actually have it on the back as well. So this is something to keep in mind. All right, now pancreatitis. So pancreatitis usually will cause epigastric type pain. So pain right here in the middle, or in the middle of the belly button, around the belly button area. And so pancreatitis, of course, is that inflammation of the pancreas. Usually it's because of a gallstone. It can also be because of alcohol, like we've talked about before. And so you want to get a good history of it. And if somebody has a history of gallstones, you want to think about pancreatitis. And if somebody has been drinking a lot of alcohol, also think about pancreatitis. The main thing with pancreatitis is this treatment is generally supportive. You want to let them eat whenever they feel like they're up to it. And then when you want to test for it, you're looking for the lipase. All right. And so next, we're going to hold off on mesenteric ischemia for now. Now, next is obstruction. So when we're looking at obstruction, we're talking about usually a small bowel obstruction. And so it can be from an actual something there. So something is blocking it off that's causing that type of obstruction. Or it can just be that your bowels are not free to move, and because of that, you're not able to push the stool forward. And a lot of times we see that in patients that have had multiple abdominal surgeries, because every time you go into the abdominal cavity, you're kind of mucking around, and you increase the risk for adhesions to start forming between parts of your bowel. So if this is your small bowel here, let's make this into actual small bowel. as you start going in and doing more surgeries, these portions of the bowel will kind of start adhesing to each other. And now when we talk about how the bowel generally moves, it moves through peristalsis. And so you have this wave of contraction, and it propagates with the length of the bowel, so that if let's say you're a piece of poop here, and the wave starts, it's going to squeeze here, push it forward, and now it's here. It's going to squeeze here, push it forward, and now it's here, and so on and so forth. And so if you can't really squeeze, or you can't really move these bowels, well, now you have this piece of poop just staying there, and it's not really moving. And so that can cause some constipation. But if it gets to the point where nothing is moving, well, now you have a kind of obstruction where you have all the stool here, but nothing else is able to go past it because it can't push it forward. And so what ends up happening is wherever this obstruction is, everything else becomes super dilated, right? And so this becomes your bowel, and with that dilation, you have a pretty significant risk of perforation. And so whenever the bowel perforates, that's always a surgical emergency, and you want to go and take care of that. So that's generally like a small bowel obstruction. A lot of times we see something like a small bowel obstruction called an ileus after surgery, because and it could be with any surgery. So whenever you're in surgery, it causes the bowels not to move as much, and it can look kind of like a small bowel obstruction. The hallmark of a SBO, or small bowel obstruction, is that when you take an X-ray and you see, let me see here. Let me see if I can draw it out. If this is your small intestine, you will see air fluid levels. And so through the bowel, you'll see these kind of horizontal air fluid levels that it's basically the stuff that's inside the bowel is settling down, and it's causing this level here. And it'll be easier to demonstrate if you see an X-ray. And that just tells us that the bowel is not moving. So that's an SBO. The SBOs are generally treated symptomatically. We keep them NPO until they start passing stool or passing gas. And so, and they're generally in the hospital for that. Now, the other side of an SBO is if it's something like cancer. So cancer, if you can think of it, or an obstruction in general, not necessarily just a small bowel obstruction, can happen in the large intestine as well. If you have a cancer, let's say here in the large intestine, well, and it grows enough where you're no longer able to pass anything through that, well, now you have a mechanical obstruction. You have something blocking here. Anything distal to that is able to come out, but all of this stuff is now filled with poop. It will start to distend, and you can back that up all the way into the small bowel and have a small bowel looking obstruction as well. And so that's an obstruction. The biggest risk for it is perforation. All right, next is DKA. Now, DKA is actually pretty complicated. It's a metabolic issue. So it's how your body is processing nutrients and stuff like that. And so with DKA, your blood sugar is super, super high. And so when the blood sugar is high, it causes, and you're not able to actually use that sugar, your body starts using ketones. And then when it starts using ketones, it starts making ketones, and those ketones are acids. And so the acid in your body increases, and it causes acidosis. Now, there's a lot of downstream effects, but the main thing is that your blood sugar is super, super high. So you're going to have people in like the 500s to 600s. It can be a little lower depending on where their body's natural glucose level is, but a lot of times I see them high, like in the 500s. And so DKA, the mainstay of DKA is giving a ton of fluids and trying to reduce that sugar. Now, and we'll go a bit more into DKA. It's probably going to get its own video because it can be super complicated. So, all right. So next is inflammatory bowel disease, and that's not to be confused with irritable bowel syndrome. So I used to always get those two confused. But inflammatory bowel disease is Crohn's and ulcerative colitis. This is an autoimmune process. So your body's attacking its own colon. With Crohn's, it's not only restricted to the colon. Ulcerative colitis, you're going to have inflammation of the colon only. It's not going to really go past that. with Crohn's disease, it can happen anywhere in the GI tract. So it can happen in the colon, it can happen in the small intestine, it can happen in the stomach, it can happen in the esophagus, it can happen all the way up in the mouth too. And so what this is your own body attacking the membrane of the bowel itself, causes ulcerations, causes, with Crohn's, it's a full thickness ulceration that can cause adhesions to other organs. Ulcerative colitis, it's not full thickness. But in the end, people come in with diarrhea, and it's usually bloody diarrhea. They're more prone to infections. They have a lot of issues down the line. So, and they're at higher risk for stuff like colon cancer. So inflammatory bowel disease is generally Crohn's and ulcerative colitis, and we'll talk about that a bit more. Irritable bowel syndrome is not an autoimmune disorder. This is the person that has that can have depression or anxiety, and they don't necessarily have to have depression or anxiety, but it's often seen with it. It's where they have a test coming up, they have increased stress, and that causes either constipation or diarrhea. And we'll talk about it a bit more, but this is generally non-surgical, and it's actually pretty difficult to treat. And so there's new studies coming out all the time for it, but it can be pretty difficult to treat. And then lastly, mesenteric ischemia or thrombosis. And so mesenteric ischemia is when it's kind of like a heart attack. It's where the vessels that supply the small bowel are occluded. So just like you have occlusion of the coronary arteries, you can have occlusion of the small bowel, and so you have decreased perfusion to that area. And so when you decrease the perfusion, now that bowel can't work as much. And so if you're thinking, how does the bowel work? Well, whenever you eat, you're making your bowel work to extract those nutrients and send it up to your liver. And so the main thing with mesenteric ischemia is you're going to have, a lot of times it's pain out of proportion to exam. That's that key word that we will see, where somebody's complaining of severe abdominal pain, and you examine them, the belly feels soft, it's not tender, you can't really feel anything in there, but they're just dying of pain. And so the treatment for that is generally supportive. The caveat is that if you have ischemia and you end up and that ischemia progresses for a long enough time, and now you end up with necrosis where the bowel itself is dying, well, that is a surgical emergency. They need to resect that portion of bowel, otherwise you're going to have perforation, and that also is a surgical emergency. It's just a messier emergency. So basically mesenteric ischemia is just like a heart attack. It's the GI equivalent of a heart attack. And you can have ischemia in your colon as well. Mesenteric ischemia generally refers to the small bowel, but in the colon it's called ischemic colitis because you're causing inflammation of the colon. The difference with ischemic colitis, though, is if you see these vessels here, and it's the same with the small bowel, but in these vessels have a pretty good blood supply, so it's harder to have ischemia of the colon. The places that we generally will see that ischemia is in the splenic flexure and the hepatic flexure. They're named after what they're close to. So hepatic flexure is near the liver, splenic flexure near the spleen. And the reason why is because blood supply generally comes in here, it comes up here, and then it kind of communicates over here. So the midpoint between those two is the area that gets the least amount of blood flow. So if you get most of your blood flow here and then most of your blood flow here, that midpoint is generally about right there. And so here you'll get relatively less blood flow, and then here as well. And there's also another point over here. And these are called watershed areas. And so these watershed areas, if you have any decreased perfusion for any reason, so if you have somebody that goes to dialysis where they're having their blood taken out of them, cleaned, and put back in, that's a huge fluid shift. That's taking a ton of blood out of the system and trying to put it back in. Well, you're going to transiently have a low blood pressure, and when you have a low blood pressure, you're going to be decreasing the perfusion to your organs. And so a lot of times we do see mesenteric ischemia or ischemic colitis with dialysis. And then if somebody's ill, like let's say they have a pneumonia and they're septic, well, they can have decreased perfusion to the organs because of the sepsis and have that issue as well. So those are generally the causes of diffuse abdominal pain. Like I said, you can have pinpoint tenderness wherever that problem is happening, but generally, if it causes inflammation of the area around it, like and you irritate the peritoneal cavity, and it starts to irritate everywhere, you can have more diffuse pain. All right, so now let's talk about the non-surgical causes of abdominal pain, and we'll break it up depending based off the quadrant they're in. So the first quadrant we're talking about is the right upper quadrant. And so we generally have the liver, the gallbladder, we can have a little bit of your kidney there. Your stomach is kind of here in the middle, but it can also cause right upper quadrant pain as well. And the pancreas is kind of traversing this area, so it can also cause some right upper quadrant pain. And so the first one we're going to talk about is gastritis. And gastritis is basically inflammation of the stomach. And a lot of times you're going to have it because somebody is taking NSAIDs, so like ibuprofen or naproxen. It's decreasing the protective barrier here in the stomach, and it's causing inflammation because of the acid that your stomach naturally produces. It can't inflame the lining without that barrier. So a lot of times you treat it with some acid blockers like famotidine or omeprazole, and it generally gets better. With gastritis, though, sometimes you don't have abdominal pain. You can have just straight nausea, and if they have kind of reflux symptoms, that helps diagnose as well. Now, next is biliary colic. Colic is a type of pain that is due to contraction of whatever it is. So if you have colicky abdominal pain, let's say this is your abdomen here, your intestine here, and you're trying to push the stool out, but now you have this blockage here because you're severely constipated. As that wave progresses so that you can try to push this forward, once it hits this area and there's this blockage, you're now distending that intestinal wall and making it bigger and causing a stretch. And that stretch is painful, and it can cause colicky pain. Same thing with the gallbladder. If you have your gallbladder over here, let's say this is your gallbladder, this is the opening of the gallbladder, and then this is the common bile duct that drains from the liver and the gallbladder itself. And so let's say you have a stone here in the gallbladder, say like right there. Every time you eat something, you eat fatty foods that your body needs bile to help break down. Well, you're going to be contracting against this obstruction. You're going to be contracting against this stone. And so that's going to cause increased pressure here in the gallbladder, causing you pain. And then eventually any cavity in the body that's not able to freely flow is at risk of forming an infection, because the bacteria just kind of sit here and start to grow and seed, and it causes inflammation of the lining of that, whatever it is. So it can be the same thing with your appendix as well. And so if you end up having that type of infection, it can cause something called cholecystitis, which I think we talked about in the surgical causes of abdominal pain. So colic, it just generally refers to that trying to push something past a blockage and causing that that pressure and that pain. So biliary colic, it refers to that. So the obstruction can be here at the opening of the gallbladder. It can be lower down near where the pancreas is as well. So that bile duct basically flows from the gallbladder into the pancreas and into the duodenum. And so anywhere in that tract, you can have that blockage. So that's biliary colic. Acute hepatitis, it's pretty straightforward. It's hepatitis. It's inflammation of the liver. So anything with the name hep in it, so like hepatitis A, hepatitis B, those are all viruses, or like hepatology is the study of the liver itself. So that just refers to the liver. So hepatitis is inflammation of the liver. So a lot of times that's going to be because of a virus like hep A, hep B, hep C, but sometimes you can get it from Tylenol use. So if you take too much Tylenol, that's toxic to the liver. Same thing with alcohol. You drink too much alcohol for a long period of time, you can have alcoholic hepatitis, where you see inflammation of the liver. It can be pretty tender in this right upper quadrant here. your liver enzymes would be pretty significantly elevated, and we just would try to, if it's something that you took, we just stop the offending agent. Depending on which virus is infecting the liver, there are some antiviral medications for it. So that's acute hepatitis. Pancreatitis, I think we've talked about multiple times. It's kind of that autodigestion of the pancreas. Typically will cause epigastric or mid-abdominal pain, but sometimes it can cause right upper quadrant pain. And then cholangitis is probably one of the most dangerous ones out of all of this. So cholangitis, so CHOL, refers to really anything that has to do with the biliary tree. A lot of times people think of it as having to do with the gallbladder, but it's a little bit more than just the gallbladder. So cholangitis is inflammation of the biliary tree. So let's draw this again. So if you have your gallbladder here, and you start draining into this is your biliary duct right here. This is your gallbladder, your biliary duct. This is your hepatic duct coming from the liver, and then over here is your common bile duct going down. So this structure right here drains all the way to the pancreas. So let me see if I can draw a little bit more. So goes all the way down here, and then this, let's say, is your pancreas over here, right? And so, and then this drains into the small intestine. So if this is your structure, right? If you have any blockage at any point in this chain, like we said before, anything that's blocked, anything that can't freely drain is going to be prone to infection. So if you had a mass in the pancreatic head, like pancreatic cancer, nothing can drain out, so though no bile can come out, you are at a high risk of having bacteria in here, seed in this area, causing an infection in this bile tract, and then that can cause pretty significant issues. And a lot of times it's an infection, but it can cause some pretty florid sepsis, and a lot of people can quickly die from cholangitis if it's not treated adequately. And so you want to be able to identify, and it's probably going to be a whole lecture on cholangitis, but what you want to look for is pain in the right upper quadrant, fever, and then jaundice. And so jaundice is because you're not able to excrete this bilirubin from the liver as you normally would because of this blockage. And so that bilirubin gets reabsorbed into the blood, and that causes a yellowing discoloration of the eyes and of the skin called jaundice. So we'll go more into cholangitis, but it's a very important thing to keep an eye on and to think about. So those are the issues in the right upper quadrant. So let's go to the right lower quadrant. So when we're looking at the right lower quadrant, the organs that we typically look at are, of course, your colon. So things going on in the ascending colon. Your appendix is also there. You have your ovary here and with the fallopian tubes there. So like ectopic pregnancies, you can have that pain, although that's more surgical. The kidneys are a little bit high up, but a lot of times the ureters that drain the urine from the kidneys to the bladder can have like a kidney stone in them, and that can cause pain in the right lower quadrant as well. And so what we're looking at here, the first one is endometriosis, and so that has to do with the uterus. So the uterus kind of sits over here in the lower pelvic area. It wasn't as big as I drew it, but with endometriosis, the inside lining of the uterus is filled with cells that basically grow as your menstrual cycle goes on, and then you shed it, and that is your period. And that lining is helpful and is important for preparation for implantation of a fertilized egg. So what ends up happening is that tissue that is usually inside the uterus itself, the endometrium, it travels outside, and it can go to areas, to organs around that area and sit on it and grow with your regular menstrual cycle. And so it can be on the colon, it can be on the uterus itself, it can go onto an ovary. And so just like you would have pain with your period, you're going to also have pain, although this pain is pretty inflammatory and can be very severe. And so so that's endometriosis, and we'll go over it a bit more in a future video. So the next one is a kidney or ureter stone, which makes sense. If you have a stone here in the kidney, you're not able to pass urine through, just like we talked about before. You block off something that's supposed to be draining freely. You can either get an infection or you have that cramping, colicky type pain as you're trying to pass whatever it is you're trying to pass, is unable to do so. And so, you with the kidney though, a lot of times you're going to have pain either on your side, your flank, or you can have pain in your back. And as the kidneys drain urine, it drains through these ureters into the bladder here. And so the stone can actually get stuck right in the middle of the ureter. And if it gets stuck in the ureter, depending on where you are, that's where you can have pain, or you can have it higher up, or it can be pain. A lot of times it's pain that radiates to the groin. And so the patients will complain of pain kind of in this distribution here. Um, and so a really important thing about kidney stones or ureter stones is if you block it off for a long time, or you have a infection there, that can be a surgical emergency because patients can get very septic and very sick very quickly. Now, a UTI can cause abdominal pain, but a lot of times it's going to cause pain right here in this mid lower area. It's called the suprapubic area. So your pubic bone is basically that front part of your pelvis, and you can feel it if you feel it on yourself. Right above that, that's your suprapubic region, and that's typically where people have tenderness and pain when they have a UTI. Now, a tubo-ovarian abscess is what it sounds like. It's an abscess around the ovaries or around the fallopian tubes. So here is a pretty bad schematic of the uterus and fallopian tubes, and the ovaries. And these, so the uterus kind of sits in this area here. Like I said before, the fallopian tubes are about right here, and then your ovaries kind of sit over here. So it kind of spans this general mid to this mid lower part of your pelvic area. And so a tubo-ovarian abscess is kind of an abscess in these parts over here, and a lot of times that happens because of pelvic inflammatory disease, or PID. And pelvic inflammatory disease comes from sexually transmitted infections, and we'll go over all of these in detail. Now, talking about the causes of right lower quadrant pain, the biggest thing in both the right lower and the left lower is for women to think about the pelvic or the gynecologic causes of abdominal pain, because some of these can be life-threatening. And I'll emphasize this many, many, many times over, but you always want to keep that in mind. All right, and so in the left upper quadrant, it's going to be similar to some other things. So like with the right upper quadrant, you can also have some gastritis, so that's going to be inflammation of the stomach. The pancreas kind of lives in that area, so the pancreas is in general going to cause upper abdominal pain. In all honesty, it actually causes periumbilical to epigastric pain. So it's around where your belly button is, but not quite the belly button. It's a bit above it, and up to where your rib cage is, right in the middle here. And then the big thing with pancreatitis is that it radiates to the back. And then the big one in the left upper quadrant is going to be your spleen. So your spleen, if it has an infarction, so if it gets clogged up, if the vessels get clogged up and you have part of the spleen die, that's going to be very painful. If it grows bigger than what its capsule allows and the capsule starts stretching, that's going to be very painful. I think I mentioned before something like EBV that can cause some splenomegaly. It can cause that pain. And then you can have abscesses in there as well. And then, of course, if your spleen ruptures, which I talked about in the surgical emergencies, that's going to be very painful. Now, in the left lower quadrant, it's going to be, again, very similar to the right lower quadrant. You're going to see that some of these things are mirrored, right? There is there's some degree of symmetry in the lower abdomen. So endometriosis is going to be the same because the endometrium that is inside the uterus can kind of go anywhere in the abdomen. I think there were case reports where they saw endometriosis in a person's lungs. I'll try to find that case if anybody is interested in it, and I can send it to you. Same thing, kidney ureter stone, same pathophysiology there. Middle smirch. So it's a funny word for basically the pain that you get when your ovary releases an egg. And it's kind of that cramping pain that you feel during your menstrual cycle. Um, and you can actually feel it on both sides. I don't know why I didn't put it in right lower quadrant. And the same thing with an ovarian cyst. If you a lot of times you have a rupture of the cyst, and that free fluid that was inside the cyst itself can cause irritation around the area and give you that pain. But it's going to be the same thing. It's in the left lower quadrant, but it can also cause pain in the right lower quadrant as well. The big one in the left lower quadrant, the one that we see the most, is diverticulitis. This is typically in elderly patients, more so patients that have had a history of constipation. And what happens is your bowels will have, if they see a lot of constipation, they're going to be under pressure over longer periods of time. So this is my bad drawing of a bowel. And so if you have stool here, that causes increased pain, increased pressure, that pressure is going to be applied to the bowel wall, and you'll have some stretch. But over time, what ends up happening is this bowel wall will end up having some degree of outpouching. You'll have this little appendage almost that is coming out. And this outpouching is what's going to cause something like diverticulosis. That's what this is called. The outpouching itself is called a diverticula or diverticulosis. When this gets blocked off and it becomes inflamed and you aren't able to drain the fecal matter that's in here, well, this is going to get infected, just like you got infected with an appendicitis. And this is going to cause pretty significant pain. You can have a fever, you can have an elevated white count, just like any other infection. And the treatment generally is just antibiotics unless it's very severe and you have a perforation of the bowel. And we'll go over that a bit more. So that was my general schematic of how to break up abdominal pain by quadrants in the abdomen, and also to sort out the things that are very important that you need to take care of right away because it can kill somebody, versus the things that you're going to have a little bit more time. So the surgical versus non-surgical causes. If you have any questions about this, I know it's a lot of information, and I know that it's going to take time to weed through this. And I feel like for the abdominal pain cases, more so than the chest pain cases, we just need to practice through them and see what the different presentations of each of these diseases are. If you have questions, let me know. We'll go over the information together. And looking at some of the scores for the pre-quiz, they were pretty low, which I had expected, although there are some people that got a pretty good score. And I think that those people probably have had experience before in this area. So don't feel bad if you feel like you did poorly. That was expected, and hopefully by the time that we go through these cases, just like with the chest pain cases, your score is going to improve. And there was a pretty significant improvement in scores from the pre and the post quiz for chest pain, so I anticipate that for this as well. If you want to support what we're doing, subscribe to the channel, like this video, and share it to whoever you think is going to be helpful. And for the new people that are joining in on this experience, welcome. If you have any questions, I know it's going to be a bit harder for you as you're trying to get into the groove of things. Feel free to reach out. I'd be happy to help.